So the first speaker today is Dr. Alison Milner. Alison is a senior lecturer at the University of Melbourne and a senior research fellow at the School of Health and Social Development, Deakin University. Her current area of research interests include the influence of employment characteristics, quality of work, job, stress, unemployment as determinants of mental health and suicidality. Alison's work ranges across a number of externally funded etiologies and intervention projects. She works with key policy stakeholders to promote research on the links between work and suicide, and is the co-chair for an international panel of research aiming to promote workplace suicide intervention. Alison also has interest in research on disability, mental health, and employment. Ladies and gentlemen, please a big welcome to Alison Milner.
Thanks, Godfrey. Yes, thank you very much. I'm here today to talk, I need my clicker, to talk about a project that Inkalink, who are here today, hello, and a couple of us have done, funded by Beyond Blue, and we wanted to put together an approach to reduce stigma and suicidality in unemployed construction workers. So, hang on, now I noticed that other people had it. So, some of the risk factors for suicide, and we went over this in some of the earlier presentations, so I won't go through it in great depth. Male, employed in construction, lack of contact with health services. What wasn't mentioned was being unemployed, and being unemployed is a much greater, those who are unemployed, are at much greater risk of suicide than those that aren't. So when you combine these factors, really we're looking at the perfect storm when it comes to unemployed construction workers. One thing that we haven't really spoken about, and I hope to touch on within this presentation, but also this afternoon when we discuss the blueprint that's being put together within the construction industry, are protective factors. So just as a bit of background, I come from a history of research within suicidal behaviours and interventions that can help people who are at risk of suicide. So this is what quite a famous academic, Morgan, said some time ago, that said, surely there's one common theme throughout the centuries, and it's the provision of human contact, the comfort of another person, conveying a message of hope. So this idea that all of our psychotherapeutic interventions within suicidality are seeking to connect someone, seeking to provide social support, seeking to just have that human-to-human connection. And, oh, hello. Yeah, and that's something that runs through this project and something we're trying to simulate using a smartphone approach. And there's some discussion we need to have around that down the track about whether we're able to do this with a smartphone. So what is social support? And social support are resources that people perceive to be available to them or that are provided by non-professionals. So these aren't necessarily something that's provided by a doctor. These are provided by friends and family and other people around the person. So there's a lot of different types, which I probably won't go through today. So there's two main hypotheses with social support. The first is that regardless of whether you're at mental health problems or not, social support will help you. And that's called the main effects hypothesis. So it's going to lift your mental health. If you're mentally well, to go and talk to someone, a friend or a family member, you're going to feel better after that. And I think probably we've all got anecdotal experiences of that happening. The indirect or the buffering effect is that social support can be particularly beneficial when someone is at acute risk of suicide or mental health problems. And there's evidence that still needs to evolve for that. To what extent is social support alone, regardless of drugs, regardless of therapists, be a form of therapy for someone? And this is sort of like what Mates in Construction is trying to do as well. So we published a paper a little while ago about the role of social support when somebody's unemployed and when they're employed. And what we basically found, we classified, this is across a cohort of about 12,000 people. Those people who had low social support, so we classified three groups, people who had low, medium and high. When those people who had low social support lost a job, they had a much greater decline in their mental health. Those people who had a medium level, like a moderate level of social support or a moderate level of social contact with friends and family also had a decline in their mental health, but it was much smaller. And those people who had high levels of social support had a very small decline in their mental health. So what this really says to us is that if people can be provided with social support, they can be buffered from the impact of a job loss. So, and that's 3.48, that's on a clinical scale that measures depression and anxiety. That's actually a clinical drop in mental health when somebody with low social support loses a job. So this tells us how important social support can be in protecting someone during job loss. And this is what I've just discussed, that unemployment is associated with the greatest decline among those people with low social support. So whizzing on now, in suicidology, in suicide studies, there has been some clinical research set in hospitals that have tried, so when someone's discharged from a hospital, they try and follow up these individuals to make sure that they are provided with support over the time they leave hospital, because it's often a very acute period of risk after someone is discharged. So the ways that clinicians have done this and researchers is they've done really simple things, like just sending a postcard to someone saying, "Are you okay? It's been a little while since you were here at the hospital. We hope you're doing all right. Can you come back and see us if you've got any problems?" And they've also sent letters saying similar things about support and hoping they're okay. So these aren't clinical tools. These are very simple, "We hope you're okay, we care about you, come back and see us" messages. And these have been found to be protective in reducing further suicidal behaviours and deaths from suicide as well. So to me, this really says, let's get out of the clinic, let's move our prevention out into the community and start connecting with people through a variety of mechanisms, working together with health services and other communities within people that are around people that are at risk. And we did another study saying, well, what exactly was working here with these sorts of brief contact interventions is what they're called. So these sort of postcards, what's going on here? The three main things that came out as being critical was social support, providing a sense of what we called suicide prevention literacy. So what that is, it's what are the risk factors around suicide, where can you go to seek help, what should you be watching out for in someone else, the sort of things that Mates in Construction provide and other organisations here, and learning alternate coping behaviours. So that really is, if you're going through a tough time, what else can you do to relieve your anxiety or your stress? Suicide is not a good option. Is there something else we can do? So these were the three main things that these sorts of interventions have done. So this is what some of the researchers have said about it, and this is quite over a long period of time. Telephone calls to someone may have reduced the sense of social isolation, enhanced connectedness, and established a sense of therapeutic alliance. This feeling of connectedness came up in all these studies. And this one's based in a hospital, so they called them green cards. So when they left, they got a card saying, "Please come back and see us if you've got any problems. We really want to be in touch with you." So these provided a way to communicate distress and let people know that people were interested in wanting to hear what they had to say. And postcards. So this is a bit of a longer quote, but I think it's a good one because it really tells us that people who are at risk of suicide feel as though they are incompetent or undeserving of care. So a service model such as this postcard intervention emphasises respect. It emphasises the connection between high quality medical care with follow-up arrangements that are able to help people after they leave. So some of the explanations for why these are effective, and this is still something we need to do more work on, but what we believe is why these work is because those with more frequent social support are more likely to access health services if they need it. So, for example, having somebody say, "Are you all right? Can I help you? Is there a way we can talk about your problems?" can help someone on the path towards recognising that they need help. Also, that persons with greater social support may actually perceive that they need less help to begin with. So this might be the case if you can be checking in with someone all the time, that they may not get to the point where they need to go to hospital. And the other really great thing about these sorts of approaches is they can go hand in hand with doctors' treatments, and they can go hand in hand with medicine as well. So, and they're very low cost, which is the other sort of side of this. So that's the sort of background and the rationale and the philosophy of what Inkalink and our universities were trying to do within this expanding brief contact interventions into non-clinical populations. So the name of our program is called Contact and Connect, So we wanted to reduce stigma and also reduce suicidality. It's a bit of a clunky name, I understand, but I actually think, I don't know, I had some feedback that it was clunky. But I thought it was really cool at the time, but I'm an academic, so, you know, I probably don't know what's that cool. So I don't think we've had bad feedback about the name, have we? No, good, excellent. So we got together with Inkalink. So Inkalink is a joint enterprise of unions and employer associations in the Victorian building and construction industry. And this is their sort of member base. They've got a really large member base of people, and they offer a wide range of services already. So, and the really great thing about working with a partner like Inkalink is they are in direct contact with people when they lose a job. So they come in and are provided with financial support, and they're also provided with psychological support if they need it. So again, this sort of approach is meant to tie in with this face-to-face contact. I don't believe that smartphone interventions alone are effective. I think smartphone interventions need to work in partnership with face-to-face approaches. I don't think we're ever going to get away from that. So the main focus of our intervention strategy was to deliver... Am I going all right for time?
Yeah, you're going.
Oh, good. The main focus of our intervention strategy was SMS messages with links out to other things like videos and infographics and postcards and text messages. So, and then we had a microsite that was behind this SMS message where people could go if they wanted to find more information on all of the things that were discussed in the text message. So we went through a few iterations of this. Originally, I always thought that text messages were going to be more important than, say, a mobile phone app. And the reason for that is, harking back to what I said at the beginning of my presentation, if somebody is provided with a message of hope and connectedness, independently of them having to do anything, then I think that's going to be better. So if somebody gets a message without them saying, hey, how you going on there? If it just pops up and says, how you going? We hope you're okay. That they don't actually have to do anything to receive that. And that's sort of why brief contact interventions are working. It's taking the onus away from the individual at risk to reach out to someone and saying, we are caring about you regardless of what you're doing. So I always had a strong belief that it should be us sending messages to someone rather than an app where somebody had to navigate their way through that to begin with. But in saying that, there were some pretty cool platforms, and we were able to embed videos, cartoons, other sort of messages of support within this SMS message. So our primary outcomes were help-seeking inhibition and shame. Those were the two things we were trying to change. And our secondary outcomes were suicide ideation. So the structure of our program was it ran for 6 weeks in total. And during that time, people received numerous BCIs, that's what we were calling them, that asked how they were going and provided different targeted messages that we hoped would support them during their period of unemployment. So in the first week they got 2, and then it sort of spaced out to about 1 a week. And the microsite, which you can see down the bottom there, underpin that all. So we were able to track traffic for how many people looked at the microsite, which things on the microsite they looked at. So we were able to now tell which bits of the program people responded to the best, which I think is a really great thing. So how did they come into the study? So first of all, we had Inkalink sending messages to everyone in their member database who were accessing services or redundancy funds. We also went on social media, so we went the conventional Facebook and other web pages. We had flyers and posters, other websites, ads, etc., and referral. But by and large, the majority of our participants came from those people who were accessing member services within Inkalink. Very, very small proportion came from Facebook or other social media sites. And that's probably another conversation about why that might not work, that sort of general recruiting of people through Facebook as much as we think it will. Well, it didn't for our study anyway, keeping in mind that we are looking at a population of men who are unemployed and probably less likely to be reaching out or clicking on something on Facebook. These was some of the content we developed. So that is the plain language flyer. And I can't really read what it says, sorry, but I should know because I think I wrote it, but basically it just explains the study to participants and encourages them to sign up and access other resources on the microsite if they want to. Here's some of the first text messages that were sent to participants once they were enrolled in the site. So this is what they got popping up on their phone. Thanks for the call. Here's the information I promised you about the program. Click here for details. So we had someone at Inkalink who was Terry, who's not here today, but who was really great about following people up and giving them phone calls saying, have you read this yet? Are you interested? You know, we'd be really pleased to have you involved. It was quite an intensive process, keeping people, one, recruiting people into the study, but two, keeping them in the study. It did require that human contact. And we had surveys at pre and post, and we hope to do one later on if we can, but at the moment we've just got the pre and post survey results for this, which I don't think I can talk about in depth today. I can talk about anecdotally, but we're presenting that in a couple of weeks. We've got to launch the sort of findings of this study. Here's some of the messages that we developed in collaboration with PubWorks, who are now called, what are they called? Creative Works, yeah. So they helped us shape some of these messages, and they helped us to develop content that would be attractive to those people that we were trying to connect with. So a lot of the infographics and also things like that. And we worked also with filmmakers and with animators to develop animations and films that would connect with people. One of the things that we knew from the films is that it had to be real construction workers. It couldn't be an actor. It had to be someone that had gone through unemployment and was able to speak about their experiences, not only with unemployment, but with their struggles with mental health or with their friends' mental health. And we did get a really good response to those films. So I think that also tells us something about these sort of social marketing campaigns, that people know when something's genuine, they can sense it. And I think that was a good decision in retrospect. So the evaluation, so we had a randomised control. So that means we had one half of the cohort getting this intervention and the other part not getting it straight away. And they're called a waitlist control. They will get this after the study is done. And that's so we could compare to what extent is the trial actually affecting people's mental health. Thank you, Godfrey. So we've done a baseline survey, and then we've done a post survey, and we hope at the post survey that those people who actually got this active intervention condition will have lower stigma, better help seeking, better attitudes towards help seeking, and lower suicidal ideation. It was a kind of complicated passage for people coming into the trial. So we had up the top there, you can see almost 13,000 people who were invited to join, and we had 868 that were registered for the program. So the majority of the people that actually ended up in our program were from the Inkalink list, as I mentioned before. And then this is the flow through the survey. We had about 680 that did the baseline, 333 who got the active intervention condition, which is Contact and Connect, and 326 who were the controls who will get it after we finish our evaluation. And we've got, we're at the stage now where we've got the majority of people who are finished, and we're currently analysing some of the results for that. We've still got some to go that are still getting the trial. So some of the sort of future directions, I would say, within this body of work, and not only within Contact and Connect, but reflecting on suicide prevention generally in workplaces, but also in clinical settings, is how can we better test what about these interventions is making them effective or not? Because I think that's critical. If we go out to do drug trials, you don't just randomly give people a blue pill and a red pill and then say, oh, the blue one's working, we're not quite sure why, but hooray, let's market this. There is better understanding of some of the biological mechanisms for why interventions may or may not be effective. We don't have that same rigour when it comes to interventions with people's psychological health, I don't think. So we need to have clear program logics that explain why an intervention is working or not. Another thing is that can these BCIs be generalised to non-clinical populations? So a lot of what I've spoken about in the front part of my talk is that brief contact interventions have been based with people who are at risk of suicide. Can they work in people who are not acutely suicidal? Is the provision of social support more effective for some subgroups more than others? So is it going to work with our cohort of people that are unemployed? Is it going to work for people who are younger or older male? We know that the effect of social support on male mental health differs by age. Younger men seem to really be more receptive to the provision of social support in cohort studies anyway than older men. So the nature of social support and how it interacts with a person's mental health changes over time. And how can we better measure social support? And that's something we have included measures of social support within Contact and Connect, but they're still pretty rudimentary. I think we need to do more work there as well. Thank you very much. I hope that was okay.
Thank you.